So welcome again. Today's discussion is focused on making the case for dental coverage for adults in all state Medicaid programs. I'm joined today, I'm Marko Vujicic. I'm the Chief Economist and the Vice President of the Health Policy Institute at the ADA. I'm joined today by Colin Reusch, who's a Senior Advisor on Oral Health Policy at Community Catalyst, and Melissa Burroughs, who's an Associate Director for Strategic Partnerships at Families USA. We're going to get into the content of today's webinar. Before that, I just want to remind folks there's a Q&A function. Please submit any questions you have. We'll have probably 3 or 4 questions max at the end, but go ahead and submit those. We will be recording this webinar as well. You'll see in a second, you'll be able to get a new report from each of our websites, the ADA's, the Community Catalyst, and Family USA. So without further ado, we'll get into this. This is a collaboration between the Health Policy Institute, Families USA, and Community Catalyst. On our end, we are missing one person who was key to this, Chelsea Foss in my group. Happily, she's on maternity leave. But she played a big part in this report that we are launching today that Colin will tell you a little bit more about.
Thanks, Marco. Yeah, and I think we're all excited to be launching this report on making the case for dental coverage for adults in all state Medicaid programs. Our respective organizations have been working on this for months. And as Marco said, Chelsea Foss with the Health Policy Institute did a good bit of the heavy lifting on this report to help us better understand what the impact of bringing every state up to a level of comprehensive dental coverage for all adults would be. Melissa?
Thanks, Colin. So, why did we spend many months working on this report? And I think, it's pretty evident that a lot of us on this call have been working on this issue for a number of years. So, where does this report how does this report take us to the next level? This really goes in depth in a review of evidence on barriers to dental care for low-income adults, reviews evidence linking comprehensive dental coverage to improved oral health, reduce medical care spending, and economic benefits. It summarizes the current landscape, but the thing that really takes us to the next level here is the data that the Health Policy Institute was able to help us, elevate, where we're estimating the fiscal impact of providing comprehensive dental coverage for adults, and then we're discussing policy options to really get to a place where we're able to do that. And the reason we're doing this now is that, as many of you know, Congress is really thinking about oral health issues and about gaps in dental coverage in a way that is far more intentional than has happened in a very long time. And while Congress may not act on Medicaid adult dental coverage in the very short term, they are starting to care. And this is really a moment for us to make sure this issue is top of mind. And so we're really excited about releasing this report and doing it now to really further the conversation and also continue to push state policymakers to make improvements as well.
And as mentioned, the report is live now at ada.org/HPI. You can also get it via Families USA's website and Community Catalysts as well. As Melissa mentioned, one of the things we summarize in the report is this stylized fact that cost barriers to dental care, number one, are the most often cited barriers to dental care. They are higher for dental care than for other types of healthcare services. This is not new information, but we update the data. But I think more importantly, when you look here, for example, on this chart, the age / income group that has the sharpest financial barriers to accessing dental care, that group is low-income adults. So that third stylized fact on the bottom, I think, is something that motivates looking at Medicaid adult dental coverage, because low-income adults of any age and income group seem to have the toughest time affording dental care. And we recently out of HPI launched some fact sheets looking at racial and ethnic disparities. I don't want to go through these all today. You can get those in detail, but I think just important to know that, for example, cost barriers to dental care have fallen for children, but increased for adults and seniors over time. And we also know that within all age groups, Hispanics and Blacks are facing far more severe cost barriers than whites. And again, this just reemphasizes the role that Medicaid plays. Disproportionately, Black and Brown adults are covered by Medicaid compared to like private insurance. So it kind of is, as Melissa said, more important maybe now than several years ago.
So, I mean, some other things that we already know, but we, reiterate and elevate in this paper, look at, the impacts of Medicaid dental coverage in improving people's lives. So there's a strong body of research already telling us that providing dental coverage to adults in Medicaid reduces the incidence of emergency department visits for non-traumatic dental conditions. Which of course help the system realize pretty significant cost savings by keeping people out of hospital emergency departments and moving them into more cost-effective settings like dental clinics or community health centers where they can get routine preventive care to get them to a state of good health and keep them there. Next slide, please. And there's also recent research showing that when adults gain more extensive or comprehensive dental coverage through Medicaid, their economic and job prospects improve. So there's some recent research out of Michigan showing that with their Medicaid expansion. But we also know, again, that this is key to closing racial disparities on the economic side as well as the health side, because the biggest impact in those job prospect improvements was seen among Black Medicaid enrollees. And of course, HPI has done quite a bit of research in the past on this economic issue and the issue of employment as it relates to dental problems. So we know that many low-income adults report that the appearance of their mouth and teeth affects their ability to interview for a job. But those barriers are much more pronounced amongst low-income adults in states where the Medicaid program does not offer comprehensive dental coverage or in some cases doesn't offer dental coverage at all. So again, bringing every state up to a level of comprehensive dental coverage is key to a sustained economic recovery. Melissa?
And it's not only key to a sustained economic recovery, but also, recovering our health as well. As, many of us have been talking about for decades at this point. The mouth is part of the body and our health is very much connected to our mouth. And so, we've seen repeatedly that increased access to dental care is associated with lower medical care costs and improved health outcomes among patients with certain conditions like diabetes. And, there are connections even to diseases like COVID-19 that really make this not only an issue that, we can focus on these cost savings, but also an issue that's very relevant to this current moment in which a lot of people nationally, whether they're policymakers or in the general public, are really thinking about health in a, more acute way than ever before. And so that leads me into kind of where we are in the current landscape for Medicaid adult dental across the states. And this is, as you can see, I'm not going to go through every state or every single category listed here, but as you can see, there are 28 states that do not offer comprehensive or extensive Medicaid adult dental coverage, although we are going to see some improvements in the coming months as states have passed legislation relatively recently, such Maine is one. But this variation is really the problem here, because Medicaid adult dental coverage is not required in states. We see that we have variation like this. We see that when budgets are tight, states make cuts. They put dollar caps on the coverage that's available. They reduce services, and then it changes a lot over time. So where we're going with this paper is looking at what would it look like if every state was green, if every state was offering comprehensive coverage, which I saw we had a question about what that looks like, which you can read more about in the footnotes of the paper, exactly how we defined it. But really, meaningful dental coverage for adults in the program.
And so what did we do as a team? So we got together and we wanted to, as Melissa said, collect all this evidence and make a data-driven case on both the problem and what we know about the policy impact. So for now, up to now, we've showed you the data are pretty clear, that cost barriers are really, really important, keeping people away from needed dental care. They're particularly acute for low-income adults and people of color. And we've shown that good policy works. Colin referenced several papers showing that when you design comprehensive coverage right, you get more people into dental care, you reduce emergency department costs, you help people in their job searches, etc. And the last part that we put together was a fiscal estimate of what it would take. So let me go through these points. So what's new in this paper and fresh is that we've costed out in these 28 states Melissa mentioned that don't have comprehensive coverage. What would it take to actually get comprehensive coverage? So this, in a sense, is saying what's the additional investment needed to get all states up to a level of comprehensive/extensive dental coverage in Medicaid. We're not going to go through the detailed methodology here, but HPI has built up a model that we've been refining over the last few years that lets us look at the predicted impact on utilization, and then we cost that out, and then we look at what the predicted reduction in different types of offsets are, like medical care costs, etc. So we have a model. We worked with several states on detailed state level reports. Like Melissa said, we've helped in Maine, we've helped in Virginia to kind of put some numbers behind this recently. But anyway, what we do in this paper is we estimate the increased dental care costs in these 28 states if they were to go to comprehensive coverage, as well as reductions in medical care costs among adult Medicaid beneficiaries who have diabetes, heart disease, or are expected to become pregnant. What's really important in this paper is that we do not estimate the emergency room cost savings. This is purely due to data constraints. As a result, we are probably overestimating the true cost, but we're very transparent. We did not have data in 28 states to be able to do emergency room cost offsets. We take account of the split between the federal and state government shares of spending according to the latest FMAP rates. And we have numbers for all 28 states combined, and we have an annex that has it actually state by state. So that's a nice thing for those of you that work at the state level. You can go in and look at your particular state. But again, those are not going to include the emergency room cost offsets. In the case you have those data and are interested in working with the three of us together, reach out to us, me or Colin or Melissa, and we could potentially do some state level results. Okay, before getting into the punchline, the numbers, what I do want to highlight is that we were able to leverage new data to get some much better modeling estimates. So not to go too wonky here, but basically we were able to access real claims data from all states through HPI's arrangement with TMSIS. And we were to get, this lets us do much better predictions. So for example, if we look here at these two data points that are highlighted by the red arrows, when we divide states into 4 groups, according to whether their Medicaid program has no adult dental coverage, it has emergency only, it has limited, or it has extensive. When we bucket states into those 4 categories and then look at things like average dental care utilization, which is this 28.4 number, It's really important to note that when you add dental coverage in Medicaid, it's not like 80% of the beneficiaries end up visiting the dentist. So I think a lot of the fiscal hawks on the policy side are skittish about kind of raising the expenditures of the government. It turns out that in the 19 states that currently do have the most comprehensive coverage, it's still only 28% of adults per year that use that coverage. So this is important, and it's the reality, and it's data driven. When you look at how much each of them on average spends, it's $400, $437. So again, the point is these are real data from actual programs. It lets us do much more kind of refined estimations of what's going on. So I will just give here the punchline. And again, you can see the detailed summary of the methods. We have a multi-page methods document. We have annexes with state-by-state results. But if you look bottom left of this table, we estimate that per year, it's about a $1.1 billion investment in dental care across these 28 states. If you move to the right, we estimate we also see $273 million per year in reduced medical care costs. And that nets out to, in these 28 states, we estimate about $835 million per year to provide comprehensive coverage for all adults covered by the Medicaid program in these 28 states. If we go to the bottom row, that's about $6 per enrollee per month on dental care spending. We expect about $1.50 in medical care savings per member per month, or per enrollee per month. And that nets out to about $4.64 per adult Medicaid enrollee per month to provide comprehensive coverage. Again, I want to read the bottom. We think our analysis likely overestimates the net costs. We were pretty conservative in all of our assumptions, and we also don't include emergency room cost savings. So these numbers are likely inflated, and the true cost is less. But again, we're analysts, and due to data constraints and stuff, that's the best we can do, but we acknowledge it's probably an overestimate. So let me turn it back now to Colin.
Sure. Thanks, Marko. So the other thing that we look at in the paper are options for actually achieving these outcomes in terms of policy. The first of which would require congressional action to make adult dental coverage a mandatory component of Medicaid. So effectively designating dental services in the federal statute as mandatory rather than optional. But in order to ensure that there is comprehensive coverage, or at least a baseline of comprehensiveness across the states, we would also recommend that Congress consider policy that expands the statutory definition of Medicaid dental services to include the full range of oral health conditions and specific categories of services that the adult population may need. In addition to that, we also recognize that in order to successfully implement a new benefit or an expansion of benefits, it could be beneficial for Congress to consider increasing the federal matching rate for dental services and Medicaid to support that. And finally, at the end of the day, the Congressional Budget Office, or CBO, would score any such legislation. And so we would want to make sure that they account for the potential medical cost reductions that Marko covered, and hopefully including emergency room spending, which is not included in our analysis, but which would result in even more significant cost savings in the long run. So that's one reason that we did this analysis, is to be able to help inform those sort of estimates moving forward. Melissa, anything that you would want to add to that?
Sure. Not on the policy specifics, but I think I'll just reiterate kind of what I was saying before about why this moment is so important. I think up until this point, we've seen a lot of good activity state by state, but there really hasn't been much appetite to address this issue from the federal level. And with the conversations that are happening in Congress now, with the experience we've all just been through with the COVID-19 pandemic, where we're headed with emphasis on economic recovery, improving health, and a lot of effort to move towards racial justice. Congress is much more receptive to these policy ideas that we've laid out here. And I think that, we may not see something like this move in this year or this Congress, or, who knows, maybe we will. But there is really a strong opportunity for us to lay the groundwork now and really make sure that policymakers are focused on these options and understanding just how important they are to, health equity, to economic improvement, to racial justice, all of those things, and improving health, of course. So I'll leave it at that, but I think, I can't understate how important the moment we're in is.
Excellent. So that's kind of all we wanted. Again, if you want to go look now at the report, it's at ada.org/HBI, and again on Families USA's website and Community Catalyst. Before stopping screen share, I do want to take some of the questions that came in that would help with some visuals. So here in this particular table, someone asked, for each state, do you split out the federal and state amounts according to the FMAP? We do in the annex give the results in the total estimate of the cost for that state, and then we give the FMAP rate. So you can just multiply those to divide it out. We didn't split out the actual dollar amounts, but all the information is there that will let you do that. Here, somebody was asking, well, the question was, do you assume current levels of reimbursement in the state for your model? Not exactly. So what we do here is you should think of it as the reimbursement rates we are assuming would be the average across these 19 states that already have extensive coverage. So this $437 on the right, that's a mixture of the quantity of services on average for adults in these 19 states combined, as well as the price, the reimbursement in those 19 states combined. And we basically apply these to the rest of the states. So we're using the reality in the 19 states that currently provide extensive coverage as a proxy for what would happen if these other states were to increase their benefit package. So that's a great point. If we were to actually require some type of change in reimbursement, that would probably up our estimates. But right now, we're taking the current averages across the 19 states with extensive coverage as kind of our benchmark. And with that, I'm going to bring us all back in. Let's keep our turn our videos on here. There we are. Colin, Melissa, myself. So let me go through some of the other questions that have come in. What's to stop adult dental care from cannibalizing children's dental coverage? So I think implicit in this question is, if there's a fixed pie for dental, are we simply moving it around? If we expand adults, we must shrink kids' investments, or would this not work that way? Who wants to take that?
I mean, I don't think that we should assume that there's a fixed pot for dental. I mean, the thing to keep in mind here is when you look at the overall costs that are assumed, the bulk of that is being paid for by the federal government, not the state governments. Okay. So there is additional support coming in, as you expand those benefits.
Okay, good. Another one related to the kind of capacity of the system or providers, or somebody just punched in private practice dentists. Are they interested in this? Let me ask a general question. What's to say we have the capacity in the system to absorb more adults going to the dentist? I mean, I'll just add that the track record seems to be in the states that have expanded. We've done pretty well. The research shows you get a lot more adults into care. Some research we did shows that's achieved through expanding hygienist hours and different productivity measures. But can each of you comment on anything else to add there in terms of the ability of the dental system to absorb more patients coming in?
I mean, I think the best thing to learn from is the experience, as you've mentioned, and I know you all have done some survey work as well that kind of reinforces that point that there's a willingness to accept patients. But I think the other piece of this is that there are ways in which Congress can continue to invest in the dental workforce as well. That may be part of both shoring up, whether it's community health centers or loan repayment programs. There are things that can ride with a new benefit that would help, even though there is capacity, make it even stronger.
Okay.
Yeah, I would agree, and I think at the end of the day, the short answer is we shouldn't stop any of our efforts to continue to expand the oral health workforce. But I don't think that concerns around capacity should preclude expansion of benefits, because, as you said, we haven't seen that dynamic play out in states that have recently expanded.
And then there were a series of questions that I'm going to lump into methodology. Somebody was asking for references for some of the slides we've shown. And I know, Colin, I think you punched in and responded in the chat. But anyway, look, the paper is short. It's heavy on appendices. It's short on the front part. You can easily see these papers we've highlighted here on the employment impacts, etc. So we won't go into that. And then one interesting question came in: are there champions in Congress for this, for like a federal mandate? Melissa, you're nodding. Why don't you start?
Sure. So Colin and I were actually just on the phone just before this webinar, exploring these options, and there are. I mean, we've seen a number of members of Congress kind of start to chip away at this in previous legislation. Senator Casey has had legislation that addresses Medicare and Medicaid coverage in the past. Senator Stabenow has had legislation around improving coverage for pregnant women. I think there's a number of these sort of oral health champions that have weighed in on a number of different coverage issues that are, happily considering the Medicaid issues as well. But we expect that, Robin Kelly is another kind of in that category. We expect that there will be legislation forthcoming, potentially even this month, likely on the House side, that would kind of show us who our next set of champions on this very specific issue are. So there definitely are champions, and more details to come. I don't know, Colin, if you want to share more.
I think you covered it well. We've got more champions now than I think we've ever had, and we're looking to cultivate more.
And certainly, I know, in our DC office, you two are in touch constantly and stuff. This certainly is an issue now that's gaining more steam within our, congressional advocacy agenda and stuff. So hopefully there's some momentum going here. And again, it was just a small analytic contribution we wanted to make to put some numbers behind what this would take. So again, for all of you joining, thank you. Colin, Melissa, thank you. It's been a great collaboration. We're going to end right on time here. Thanks for joining. And again, this is recorded. Share away. The reports are online. Please share with your legislators, with your advocacy groups, with whomever. This is all in the public space. And have a good rest of the day. And again, pleasure working with you, Colin and Melissa, as always.